In terms of complex trauma best practices, there's a bit of a challenge to finding best practices for complex trauma. For one, it's new. When we think of trauma, we think of the acute, a car crash, saying a murder, a specific incident where you feared for your life. We don't think of the slowly eroding factors that can influence people, let alone small children who have not yet learned how to monitor arousal. Because of this, it took time to realize that these practices that we had research for, didn't work on everybody. We had an answer, we did research, we had proof, and then there were these kids who just couldn't use it. So we had to go back to the drawing board. Children who've been victims of complex trauma, and often complex and acute trauma, who've grown up in a disorganized attachment environment, are the hardest of the hard. Because of this, Lisa Jackson and Ruth DeRose warn against using evidence-based practices for these kids. EBT has been described as an inflexible, cookie-cutter approach, blindly following research findings without regards for the best needs of the particular client. Trauma clinicians all over the country are currently debating what to do with clients with more complex presentations. They have identified the top 5 reasons for not necessarily including EBT. 1, the research base is not always convincing. 2, they are difficult to implement with these clients. 3, they require change that may not be actually significant or meaningful at this point in the life of the child. 4, they're incomplete given the problems that are currently faced. And 5, the infrastructure for implementation does not always exist or is not always supported. What is being asked is questions regarding childhood trauma for issues like comorbidity, diversity with clients, issues around the primary caregiver, the major changes in regards to the age of the client, etc. Also, one of the major complications is that trauma is very hard to diagnose in children, specifically complex trauma. So having an EBT for it can be a little bit more difficult if we have a hard time even diagnosing it. Frequently, we notice that the child is having behavioral problems, and we assume that that's the child's nature. In the article on the impact of trauma on children, Lubit articles that society will spend thousands of dollars helping a child with physical injury caused by violence. But it often does nothing to help with the emotional impact that can markedly disrupt the child's future well-being. Common trauma-related diagnoses that you may see with your clients are such things as PTSD, RAD, ADHD, operational defiant disorder, and conduct disorder, if we diagnose anything at all. What we specifically see in these kids is the temperament and behavioral, not what has happened to the child and what their limited capabilities might be to actually process it. So if we have a hard time diagnosing it, and the best practices that we have for trauma don't work, what does that leave us with? These kids definitely need help. What we can do, what we have now, instead of an inflexible EBT, is a more malleable evidence-based guideline. If the child in your caseload has complex trauma and the interventions are not working, look to these guidelines instead, because the most important thing that we can do is to help our clients, regardless of prior notions of practice. The guidelines of treatment of complex trauma include the following. 1, safety. Clients who've experienced complex trauma often develop a base expectation that the world is dangerous. As a result, they operate in a self-defense mode and are unable to shift from being on the defense. We have to get them past this point to do any real work. To do this, we have to understand that these kids often perceive threat as omnipresent. One of the hardest goals is simply no danger here. But until you can get past that, the feeling of being unsafe is hardwired, and it takes a tremendous toll on the immune system, functioning, and well-being. Self-regulation is 2, specifically of the body, emotion, and behavior. If you're unable to self-soothe, you're unable to deal with any kind of trauma. This is often the hardest goal and the most important for continued success. 3, to be able to self-regulate, you have to co-regulate. As mentioned before, a body needs to be taught how to regulate. This is most often done by a parent when the child is an infant. But if it's not done, the child has no idea how to teach themselves how to self-regulate properly. This is an important goal to create a relation with the child, to co-regulate and attach. Self-regulation is 4, and important in terms of learning such questions such as, who am I? How do I make sense of the world around me? How do I understand my experience? 5 is positive affect attachment. What is not understood about these children who have been subject to such intense trauma is that they have no idea how to be kids. They don't know how to play, how to imagine, how to seek achievement, how to think beyond the immediate. The 6th and last step is trauma experience integration. The most important thing to know is that you cannot do trauma integration until you know that you're safe, until that you know who you are and how to make sense of the world around you, until you know how to relate, etc. It is for maybe this reason alone that EBTs for acute trauma do not work on complex trauma. They do not work on these kids because EBTs for acute trauma focus on trauma integration, and you can't do that until you're really able to understand and process it. It's that reason alone that these guidelines are so important. So what I'm going to outline for you now is 2 examples, and they're not really best practices, but more best practice models that use these guidelines. These include developmental repair and integrated treatment of complex trauma. Developmental repair is a paradigm shift in working with very at-risk children. It's an intervention for young children ages 3 to about the 3rd grade who need intensive early intervention because their aggression and their behavior is harming themselves and others, and they've been unable to benefit from the usual resources. It's not about returning the child to infancy, but it is about understanding how these disruptions in their early experiences support normal social and emotional learning and put these children at risk. It's a framework for interventions that can help children access new learning and positive community support so they can heal and grow. How developmental repair fits within the guidelines that are aforementioned is as follows. First guideline being safety. In developmental repair, the first focus is making sure that child feels safe, and it's often the most continual goal within the program. The second, in terms of self-regulation, is a main therapeutic process. It's done through group setting by helping children learn to self-regulate by the regulation of other children. It's done in individual therapy as well as family therapy. One of the main terms is called hiring, where the child actually hires you to be able to be their co-regulator. And that leads us to the third part, which is relational engagement and attachment, for that co-regulation to learn to self-regulate. 4, this is also done within group work, which happens 4 times a week. In terms of each group activity is focused on how to do that self-reflective informational processing. The positive enhancement is honestly what occurs throughout the entire time that the child is involved in developmental repair, in which the child simply learns how to be a child. The last piece is a year of intense therapy to identify and integrate that traumatic experience. The next model is integrated treatment of complex trauma, which came out of attachment and CBT models. It's a variety of components, including affect regulation, cognitive therapy, relationship processing, which are differentially utilized according to each problem or issue. In addition to individual therapy, ITCT often involves collateral, family, and group therapy. Parental education classes are also provided for caretakers who are struggling with parental issues. This has been adapted for school-based clients and students experiencing a traumatic loss, community violence, parents' substance abuse, exposure to domestic violence, etc. Adaptations of these components can be made for younger children, but a strong emphasis on symbolic and expressive play, shorter individual therapy sessions for child clients, and an even greater emphasis on collateral and family sessions to facilitate appropriate caregiver support and parenting skills. How ITCT fits within the guidelines is with the following. The first one being safety. They specifically actually focus on a safe training and safety plan. 2, the general goal for a child is to learn behavioral self-control rather than solely trying to avoid or suppress behaviors that lead to punishment. The third, there's parent and child family sessions to really do the relational attachment within the main caregiver. The fourth is an access to crafts to understand self-awareness. The fifth is focused on celebrations, planning for the future, learning to really get that child how to learn to think towards the future. The last one is actually done through a personal narrative, and again is the last thing that they are able to do in this therapy.
Traumatized children and their families are often involved with multiple services. Child welfare workers are in a unique position to coordinate and promote cross-system collaboration. A crucial best practice approach is collaboration among team members. This means taking a complete trauma history and sharing it with other team members. The team members may include, but not limited to, a social worker, parent, foster parent or guardian, teacher, attorney, mental health worker, and a supportive and a caring judge. When the team works together, they can be a strong force towards the recovery of the maltreated child and reducing the risk of the system-generated trauma. In addition, being educated about the impact of childhood trauma, the team is able to have a common knowledge and understanding of the child's trauma history and can operate successfully to meet the needs of the child. Another best practice is the importance of prompt and consistency in gathering information and sharing this information, especially during the investigation of the traumatic events. Thorough assessment can identify a child's reaction and how his or her behaviors are connected to the traumatic experience. Thorough assessment can also predict the potential risk behaviors and identify appropriate interventions that will ultimately reduce the risk. In addition, this information is essential for the court to make informed decisions regarding further comprehensive trauma assessment, the welfare of the child, the services that can be put in place for the child and his caregivers. Some of the tools used to administer a thorough assessment can be found on the National Child Traumatic Stress Network.
We recognize that child welfare is a high-risk profession. Child welfare workers are often confronted with danger and threat. In addition, child welfare workers may have experienced secondary trauma for listening and feeling what many of their clients go through. For workers who are parents or who have histories of childhood traumas, they're at a particularly high risk for experiencing helplessness, anger, and fear themselves. It's important for child welfare supervisors and directors to be understanding and to do what is necessary to provide the support to help child welfare workers do their job effectively. As covered in our introduction, the reason that the impact of trauma is so important in the child welfare deals with the key characteristics of the setting. The following was touched on in the introduction. 1, young children in the child welfare system are not receiving the services and support they need to meet their social and emotional, relational, developmental needs. 2, more than half of the agencies did not systematically require mental health evaluations. 3, only 52 of states included relationship-based treatments. And lastly, a study in child welfare showed no improvement as a result to mental health services.
In specifics, this is what we see in regards to children dealing with trauma in the child welfare setting. We know that children removed have extremely high risk for mental health problems. We also know that many organizations fail to gather crucial information on trauma. The National Child Traumatic Stress Network recently conducted a national survey of stakeholders who represent child welfare agencies, mental health agencies, family and dependency courts, foster care systems, and schools about the type of trauma information and training they receive. The representative sites included 53 interviews in 11 geographically diverse locations in 10 states. The report, Helping Children in the Child Welfare System Heal from Trauma, a system integration approach, found that children removed from their home due to abuse, neglect, and placed in child welfare system have extremely high risk for mental health problems, especially traumatic stress. The survey described a lack of consistency in obtaining a complete and thorough trauma history of a child involved in the child welfare system and in communicating these histories to other professionals. It was also found that overall, agencies did not always receive detailed information on a child's trauma history at the time of referral. The survey further found that less than half of the agencies surveyed, which is 44.7%, said that they trained their staff about evidence-based treatment for children with trauma. 61% said they trained staff on how to assess for trauma in children.
Because of the importance of trauma in children's mental health and child welfare, there needs to be changes to policy and procedure to be able to continue our work effectively and to be able to improve our work. To understand more about this, please go to the section Policy and Future Directions, Continuing Dilemmas and Unresolved Issues by Anna.